Good morning friends. Today we are discussing subject wise question bank. Question bank is from medicine. The first question is question number 1. The answer is D. FeV1 by FVC along with compliance decreases. The various examples of restrictive lung disease are ILD, sarcoidosis, kyphosis, scoliosis, and disease of neuromuscular dysfunction. Question number 2 is regarding Reid's index. The answer is A, chronic bronchitis. The normal value is 0.44. Anything above 0.52 is abnormal. It is a histopathological hallmark for chronic bronchitis. Question number 3, the answer is A again, Board's index. It is body mass index airflow obstruction, dyspnea and exercise intolerance. BODE, Board's index. It basically prognosticates long term outcome in patients of COPD. The score is from 1:10. Question number 4 is regarding pulmonary hypoventilation. It is regarding primary pulmonary hypoventilation. Primary pulmonary hypoventilation. So, the basic defect is in chemoreceptors. So, there is persistent raise in PCO2 and fall in PO2. So, all the signs of CO2 narcosis, will be present. Question number 5 is regarding asthma. The answer is D. Expectoration is a hallmark of bronchitis. Expectoration is a hallmark of bronchitis. Wheeze is a hallmark of asthma. Remember, sometimes cough can be also be a hallmark of indolent asthma. regarding intractable cough, remember three things. First is post nasal drip, second is gastroesophageal reflux, and third is cough variant asthma. Cough variant asthma. So, these patients will present with recurrent intractable cough, which is hard to diagnose. Question number 6 is regarding refractory asthma. Answer is A, omalizumab. The dose is 150 to 375 milligram subcutaneous every 2 to 4 weeks, particularly in patients having refractory asthma. The other indication of omalizumab is chronic idiopathic urticaria. Question number 7 is regarding severity of pneumonia, curve score. Answer is A. Apart from curve score, we have other pneumonia severity index such as port score. It identifies three things: demography, what is the age, sex of patient, where does he stay, then his clinical features, signs and symptoms. So, technically port score is better as compared to curve score, but curve score is easier to use, port score is meticulous to use, difficult to use in fact. Question number 8. Answer is B, Pneumocystis carinii or Gerovesi. Remember, it is not only HIV or AIDS where you can have pneumocystis. You can have pneumocystis in chronic steroid intake state. You can have it in cirrhosis, chronic renal failure, because these two are inherited, these two are inherent immunocompromised state. Then you have organ transplant states, immunocompromised medicines. So, it is not only HIV or AIDS, various other immunocompromised state can also predispose patients for Pneumocystis jirovecii infection. Important point is, these patients, they do not respond well to antibiotics and supportive treatment. However, steroids play a mainstay in treatment of these patients. Question number 9. This is regarding aspiration pneumonia. The answer is B. I am so sorry. Answer is B, tachypnea. See, cyanosis can be present in large pneumonia. Cyanosis can be present in big consolidations. Because of decreased PaO2 because of ventilation perfusion mismatch. You may have crepitations, which are signs of consolidation. You can have tachypnea, which is a compensatory respiratory effort and also a sign of sepsis. Lastly, rhonchi. One thing I want to highlight, that rhonchi can be present in pulmonary edema too because of peribronchial cuffing by fluid. So, early pulmonary edema you may find rhonchi, so do not confuse it with bronchospasm because of bronchial asthma. Question number 10, answer is D. It is regarding oligoarthritis, because the differential in this question is basically between two, that is allergic bronchopulmonary aspergillosis and Wegener's granulomatosis. Now, oligoarthritis is involvement of 2 to 4 joints within 6 months of disease onset. Again, this can be of two types: persistent and extended. Means after the end of 6 months, the involvement of joint is between in the range of 2 to 4. In extended, after the end of 6 months, you may have involvement of more than 4 joints. That is the only difference between oligoarthritis, that is persistent and extended. Question number 11, it is regarding Mcconnell sign. Answer is C, pulmonary embolism. Basically, it's what is Mcconnell sign? It is apical hypercontractility of RV, right ventricle. So, there is TR, there is RARV dilatation, there is TR, RARV dilatation, increase in pulmonary artery pressures and apical hypercontractility of RV, which is a classical sign known as Mcconnell signs of pulmonary embolism. Three important signs for pulmonary embolism in X-ray are Fleschner's, Hampton's, and Westermark. Fleschner's is increase visuality of pulmonary artery. Hampton's is wedge shaped opacity, that is infarct, and Westermark is pulmonary oligemia. So, this is Fleschner's, Hampton's, and Westermark. Question number 12, answer is B, Question is self-explanatory regarding primary spontaneous pneumothorax. All of us know that it occurs in males, young, thin individuals. The risk factors are morphinoid habitus, and lungs are non-pathological. Remember, lungs are non-pathological. They don't technically have any parenchymal or pleural disease as such. Question number 13. Again, it's a self-explanatory question that cholesterol crystals are found in myxedema. Cholesterol crystal in pleural effusion is found in myxedema. No need to explain this further. Again, question number 14. The best space to put a needle for thoracocentesis is 7th intercostal space in the mid axillary line. You have to remember it. Regarding question number 15, this is regarding sarcoidosis. Answer is A. Do not confuse it with CD4, CD8 count in blood. We sometimes can make a mistake. Remember, this is CD4, CD8 count in ball, which is important. This is in ball, which is important for sarcoidosis, not in blood. This is for HIV. This is for sarcoidosis. Question number 16. Answer is B. Primary pulmonary hypertension. You know, the FVC is normal, FEV1 by FVC is normal. Exercise cause drop in saturation, and there is pulmonary hypertension. The disease is idiopathic and usually occurs in females of younger age group. Question number 17. Murmur of Corpulmonale. Corpulmonale is TR. What is corpulmonale? It is dilatation of RV. This is corpulmonale. It can be acute, it can be chronic. The best example for chronic is mitral stenosis, COPD. Chronic pulmonary hypertension. In acute corpulmonale, you can have pulmonary embolism, a large consolidation. All right. Question number 18. This is regarding bronchogenic carcinoma. Answer is D. I am extremely sorry, the explanation which is given in the explanation booklet is wrong. This is the explanation given is regarding small cell carcinoma lung. See, bronchogenic carcinoma with parathyroid hormone related peptide cause increase in calcium levels, whereas small cell carcinoma lung because of calcitonin causes decreased serum calcium, hypocalcemia. So, this question is regarding a patient having bronchogenic carcinoma. The clinical features of pain abdomen, nausea, vomiting are cardinal features of hypercalcemia, but the explanation which is given in the booklet is regarding small cell lung carcinoma. We are very sorry for that. Question number 19. Answer is B. Again, it is a self-explanatory question that the patient has non-productive cough, weight loss, hemoptysis, grade 3 clubbing and a shadow in X-ray. So, the most likely diagnosis is non-small cell carcinoma lung. Question number 20. The answer is A. Remember, hemoptysis may not always present to you with an abnormal X-ray. With a normal X-ray, hemoptysis can occur. Remember, mitral stenosis as an important cause for a normal X-ray giving rise to hemoptysis. Bronchogenic adenoma, bronchiectasis sicca, these are few conditions where you can have a normal chest X-ray, but you can have a florid hemoptysis. Question number 21. Vinyloreblin is used in the treatment of NSCLC. No need to explain this. Again, question number 22, answer is, so question number 21, answer is B. Question number 22, this is regarding carcinoma not due to smoking, answer is D. Carcinoma of nasopharynx, right? Again, a self-explanatory question, no need to explain it. Question number 23. Well, this question is a classical question of air embolism, classical air embolism. You know, air embolism can present to you with flat and tidal reduction in CO2 level and tidal reduction in CO2 levels. Remember this, classical air embolism. Question number 24. Akinetic mutism. Well, akinetic mutism, the lesion is frontal. Akinetic mutism, discovered in 1941, probably first described in 1941, not discovered, and the lesion is frontal. The patient is mute, that is he does not speak. The patient is akinetic, that is he does not move. He has a will to do movement as well as to speak, but there is a counter will which prevents him in doing so. This is what people say regarding akinetic mutism. Question number 25. Kluver-Bucy syndrome. Answer is A. Remember, seizures are a cortical phenomena. So, anything occurring below the cortex should not produce seizure, and Kluver-Bucy syndrome, the lesion is medial temporal lobe and it is a subcortical lesion. So, seizure should be absent. Question number 26. It is regarding Vernix area damage. Answer is A. See, there is no need to explain it. Vernix area means receptive problem in reception. Even if you have comprehension which is intact, the reception is impaired, so you are not able to receive proper signals. You are able to hear, but Vernix area is not able to coordinate things well. So, what you speak is irrelevant, what you speak is rapid. People may not be able to understand what you are speaking, right? That is Vernix aphasia. By reception, you should not confuse it reception through the ear, reception in the brain, sorry, reception in the brain. Question number 27. This is regarding loss of social inhibition. The answer is again frontal cortex. You know, frontal lobe plays a very important part in inhibition, because there is a phenomena known as disinhibition, which is there since when we are born. So, frontal lobe development, you know, if you trace the development of human brain, the best developed parts are cerebral hemisphere, and particular development is of frontal lobe, and frontal lobe plays a part in suppression of our primitive reflexes, and therefore, social inhibition loss occurs in frontal cortex problems. Okay. 28. The answer is B. Basilar migraine. You know, few things should be remembered for basilar migraine. The symptoms can be very similar to posterior circulation syndromes. So, it could be myriad symptom, it could be medial medullary syndrome, it could be lateral medullary syndrome, it could be what not, right, but they are waxing waning, right, they comes, they goes, they comes, they goes, they do not transiently fit into a classical definition of TIA, RIND or stroke. Question number 29. Cluster headache. Answer is A. Again a self-explanatory answer. It usually affects males, not females. Right. Eye signs are important. You may have redness of the eye of the ipsilateral side, you may have lacrimation of the eye of the ipsilateral side. Question number 30. Anterior cerebral artery occlusion can cause contralateral lower leg weakness. It is again a self-explanatory question and a self-explanatory answer. Nothing to explain it. The answer is B.